Buenas tardes, and muchas gracias to Dr. Uscanga and Ramis, and especialmente muchas gracias to Dr. Valdivinos for inviting me here. I'm going to be speaking on obscure gastrointestinal bleeding, and the presentation will be based on the American College of Gastroenterology guidelines that I had the honor to participate in, along with Dr. Lauren Gerson. Dr. Gerson passed away this year, and so I do want to dedicate this talk to her and her career. Muchas gracias. So we'll go ahead and get started. And I'll start with a case. This is an 84-year-old female with a 2-year history of iron deficiency anemia and guaiac-positive stools. And her hemoglobin was ranging from 8 to 11, but she was requiring transfusions every other week. And she had been extensively studied with different procedures without any obvious cause. So, of course, I'm speaking on capsule endoscopy, so what test would you do next? And we did perform a capsule study, not necessarily expecting much to be found. Let's see. The video is not working. I don't know if we can... We did test it on the other computer and it was working. Oops. So I don't know if we can, oh, there it goes. Maybe a little slow. So if you watch the video, you'll see that most of this all looks very normal. And right there was a abnormality. And we did not know if that was vegetable matter or whether it was abnormal. But because she had been having so much problems, we did want to study it more. But this lesion was seen in only one frame. So we then went to deep enteroscopy. And again, I went down 400 centimeters. Again, didn't think that we would find anything. And then there was this lesion, which turned out to be a polypoid hemangioma. And so it gives you an idea of what we now can do with small bowel imaging. Now, historically, before we wrote the guideline, and before capsule and deep enteroscopy and cross-sectional imaging was available, we defined obscure bleeding as bleeding of unknown origin that persists or recurs, and it can be obscure overt or obscure occult, after a normal upper and lower endoscopy, and perhaps even second look endoscopy. But what I would like to communicate today is that since then, with improved detection and treatment of small bowel lesions due to advances in both endoscopy and radiology, we felt that it was time to modify the definition. So we suggested in the guideline that we consider a small bowel bleeding source in patients after normal upper and lower endoscopic evaluation, including second look endoscopy. And patients should be classified as having potential small bowel bleeding prior to capsule endoscopy and other small bowel imaging techniques. And so in that case, the term obscure gastrointestinal bleeding should be reserved for patients not found to have a source after these new small bowel imaging techniques have been done. As most of you are aware, you can either do capsule endoscopy, deep enteroscopy, or cross-sectional imaging, and I'll try to cover all of those. Capsule endoscopy, there are 4 capsules available at this time, and as far as we can tell, no significant difference in head-to-head comparison trials on their detection. The most unusual one is the newest one, which is CapsaVision in the right lower corner, which has 4 cameras and looks circumferentially instead of the normal straight ahead appearance. And then for deep enteroscopy, we have double balloon, single balloon, and the spiral overtube. And what's nice about these is that it allows biopsy and therapeutic intervention when necessary. And if you look, there are studies, several studies looking at concordance between deep enteroscopy and capsule endoscopy. with a moderate overall kappa. And the bottom line in terms of conclusions is that capsule and double balloon have good agreement, mainly for vascular and inflammatory lesions, and less so for polyps and neoplasia. And in that case, the double balloon really complements capsule endoscopy, particularly in patients with single mass lesions. But in addition to that, in this study, double balloon clarified the origin of bleeding in 2 out of 3 patients where capsule endoscopy only showed blood. So again, we see them as complementary. So in the guideline, we suggest the capsule should be the first-line procedure after second look endoscopy. If proximal lesions are suspected, then that would also include push enteroscopy as part of the second look. Capsule usually should be performed before deep enteroscopy because there are studies to suggest that it does increase the diagnostic yield. And a negative capsule is associated with a lower risk of rebleeding overall. And what we have found is that capsule as a screening tool prior to deep enteroscopy increases both the diagnostic and therapeutic yield. And as I said, a negative capsule allows for the avoidance of deep enteroscopy in patients with a low pretest probability for small bowel findings. And in this meta-analysis, which also looks at that, you can see that the pooled diagnostic yield was equal, not statistically significant between capsule and deep enteroscopy. But when you look specifically at deep enteroscopy, the diagnostic yield increased to 75% if performed after a positive capsule, and was only 27% performed after a negative capsule. So we can use these technologies to work together. Now, sometimes we don't always do that, and this was a 70-year-old male with an LVAD placed on warfarin aspirin, and Dr. Abraham's going to talk all about cardio-gastroenterology. But in any case, we could not find a source. Colonoscopy showed dark clots of the cecum, and we proceeded with capsule endoscopy. And you can see here again that we find blood, and the blood was at 30% of the small bowel transit time. So we decided to do antegrade deep enteroscopy. And again, it did not show a specific lesion. But when we were able to go down with deep enteroscopy, and hopefully we can get this to kick in, you can see that we did find at the time that we went down a adherent clot. What we do in those situations is we first inject with 1 to 10,000 epinephrine, and then typically we'll use APC to treat the lesion. And then after we feel that we've gotten good hemostasis, then we always tattoo the lesion in case we have to go back down. So again, you get the sense that capsule and deep enteroscopy can work very nicely together. Multiple studies have shown throughout the years that the diagnostic yield seems to be better both in capsule and deep enteroscopy with overt versus occult bleeding, and this bears that out. But remember that even for iron deficiency anemia, in this systematic review, the pooled diagnostic yield was 47%, and the pooled diagnostic yield in studies focused on iron deficiency anemia, of which there were 4 studies, was close to 67%. So still for iron deficiency anemia, these can be very useful tests. Moving on to radiology, we know barium studies shouldn't be performed. We prefer to use CT enterography as the test of choice, particularly if the capsule is negative, and it's preferred over MRI imaging. And CT enterography should be considered before capsule in the setting of Crohn's disease, prior radiation, or obstructive symptoms. Also, you should perform cross-sectional imaging if there is a high clinical suspicion, even if they've had a prior standard abdominal CT. And then finally, although we don't use it very often, pharmacologic provocation can be considered in truly refractory cases. Multi-phase CT scanning is very useful for acute small bowel bleeding, and we use this quite a bit. And it's a pre-IV contrast imaging, then followed by rapid bolus. And there is dual energy CT now, which reduces the radiation. But you can see here, the yellow arrow on the right shows a persistent bleeding lesion through all phases, and you can see it's increasing over time. So multi-phase CT angio without oral contrast, because you want to do it quickly, should be considered, especially when endoscopy is not diagnostic. Having said all that, still in this comparative study that my colleague presented, CE was superior to multi-phase CT for small bowel disorders in this meta-analysis where we looked at 10 studies. And you can see that the pooled overall yield was higher with capsule than CT. And mainly due to higher detection of vascular lesions with the capsule. Again, there was no difference in inflammatory or mass lesions. So this data suggests the capsule is still first test of choice in the setting of suspected small bowel bleeding. And then finally, we come to deep enteroscopy, and of course, this is an important adjunct to what we do. What we do know is interesting that, not surprising, the diagnostic yield of capsule deteriorates over time, as you can see here. So it's best to do it within 3 weeks and ideally within 1 to 2 weeks. And the same applies to deep enteroscopy. And you can see here that the overall yield within the first month is 84%, and it drops to 57% after that. So you want to investigate these people very urgently. Sometimes, though, because of that, you want to do a quick study. This is a 73-year-old with end-stage liver disease with hematochezia, had esophageal varices without stigmata bleeding, and had multiple procedures, all negative, including push enteroscopy. So we decided to bypass capsule and go to deep enteroscopy. And sure enough, we found a jejunal varix there on retrograde. And what we did was we brought in our hepatology colleagues who injected the fibrin glue and was able to stop the bleeding. So there are situations where you're not necessarily going to always use capsule. But I think a reasonable approach, again, is that for most small bowel bleeding, capsule should be performed before deep enteroscopy. If you have somebody who's actively bleeding, particularly in the hospital setting, that is a case where you may want to go straight to deep enteroscopy. If no source is identified, then consider CT angiography. And remember, for obstructive symptoms or suspicion of IBD, then would recommend CT enterography or MR enterography. One of the challenges has to do a little bit with epidemiology and natural history. We know that lesions correlate with age, but not gender or ethnicity. Angioectasia are the most common lesions, particularly in the elderly. And there are clear-cut risk factors, including advancing age, aortic stenosis, renal failure, LVADs. And recurrent bleeding from angioectasia correlate with a number of lesions, advanced age, presence of comorbid conditions, and anticoagulant therapy. The challenge, though, still lies in when you do a capsule and you see a non-bleeding angioectasia like you see here in the picture, the question is that bleeding? And so there's uncertainty whether angioectasia detection and ablation will affect the long-term outcome because most angioectasia are not actively bleeding when detected. And even though we find a bleeding source in up to 80%, rebleeding occurs in as many as 30 to 45%. So we need better outcomes studies on this. And this looked at long-term outcomes, still not great for patients undergoing capsule and deep enteroscopy for vascular lesions. And you can see here that 35% had rebleeding during 1 year of follow-up. And so I think this is a sign that we have to improve our diagnostic and therapeutic capability in patients bleeding from small bowel vascular lesions. This was another study looking at rebleeding risk following endoscopic therapy. And most, again, are angioectasia. And you can see that rebleeding still occurred in 40% after a mean follow-up of 23 months. And what I've learned from this is that if you treat angioectasias, you have to expect rebleeding, and it may take, if it is in fact angioectasia, you probably have to do several sessions before you're going to effectively fix that individual. In terms of medical management, there's nothing wrong with iron supplementation or RBC transfusions, depending upon the situation and as long as you ruled out something serious. But there have been challenges in pharmacologic management because the studies have been mixed. I think at this point we feel that there's no benefit from hormonal therapy, but the somatostatin analogs may help, and you can see here that in this pooled meta-analysis there was a clinical response and decreased transfusion requirements with somatostatin analogs. And then in a study with thalidomide, there was a reduction in transfusion requirements. So there are some benefits, but they're limited, and these drugs do have side effects. But it's something that we should be using more of. Now, in the setting of recurrent bleeding, which we all see quite often, the next steps are not completely evidence-based, and we need better studies. But don't forget second look endoscopy, because we know there are still lesions that we miss within the reach of standard endoscopy. In the setting of recurrent bleeding, then you have to decide whether you're going to use a repeat capsule, whether you're going to do deep enteroscopy from the opposite route to complete total enteroscopy, whether you're going to use CT enterography or angiography, or whether you resort to medical therapy to treat these patients. And in many elderly patients, this is the way to go. There's limited data and limited clinical, but clinical experience suggests the benefit in most cases for some type of intervention. So in summary, the majority of cases of previously termed obscure GI bleeding can now be classified as small bowel bleeding. Capsules usually the first test of choice. Endoscopic techniques such as capsule, deep enteroscopy, as well as cross-sectional techniques can really help localize small bowel bleeding sources, and I would think of them all as complementary. The type of bleeding and the timing of procedures is important to increase diagnostic yield, so we really need to evaluate as soon as possible close to the bleeding event. And when it comes to vascular lesions and outcomes, we need to study them more and improve our treatment. Thank you.